Hello and welcome to my channel. In this lecture we'll discuss the CSF, so let's start. The CSF volume averages around 150 milliliters of fluid, watery fluid, but turnover 4 times a day. So it's formed 4 times a day, so that's around half a liter formed every day. And of course it fills the subarachnoid space and the cerebral ventricles, the central canal of the spinal cord. Now there are localized collections of CSF other than the ventricles called cisterna. One of them is at the lamina terminalis. One of them is between the crus cerebri or the cerebral peduncles. It's called the interpeduncular cistern, and there is one in front of the pons called the pontine cistern, and a supracallosal cistern, and the one above the cerebellum, it's called the cisterna ambiens. It's where the great cerebral vein lies and passes through. It's above the cerebellum here. And the largest is the cerebellomedullary cistern, which is called the cisterna magna. And this you can, some doctors get access to the CSF through this cistern at the base of the skull, beneath the cerebellum. It's called cisterna magna. Now the ventricles, they are derived from the lumen of the neural tube, as we discussed before. And of course the ventricles, they are a space, so adapts to the surrounding walls, hemispheres and diencephalon, pons, etc., medulla and cerebellum. The largest is the lateral ventricle. This is the lateral ventricle. It has anterior horn, which is called frontal, body in the anterior horn, in the frontal lobe, body in the frontal and parietal lobes, and posterior horn in the occipital lobe, and inferior horn in the temporal lobe. This region where the body, the posterior horn, and the inferior horn meet is called the atrium. This is called the atrium. The ventricles are lined by the choroid plexus, and they communicate through the interventricular foramen of Monro beneath the fornix, and at the same time connect both lateral ventricles to the third ventricle, which is the space between the two thalami. Now back to the lateral ventricle. Anterior horn, anteriorly it's the back of the rostrum and genu of the corpus callosum. Here should be the corpus callosum. So this is the region of the rostrum and genu of the corpus callosum. Medially, it's the septum pellucidum. The septum pellucidum is the septum that separates the two lateral ventricles. See that? This is the septum pellucidum. The floor of the lateral ventricle of the anterior horn is the head of caudate nucleus, as we saw in horizontal sections of the brain. The roof is the anterior part of body of corpus callosum. I told you before that the corpus callosum lies above the lateral ventricle. The posterior horn, which varies in size, by the way, roof and lateral wall, is formed by the optic radiation, and we saw that in horizontal sections before, separated by the tapetum. Remember the part of the corpus callosum called the tapetum? It forms the roof and lateral wall of the posterior horn. Medially, the bulb of forceps major, which is part of the corpus callosum, and a structure called the calcar avus. It's simply the floor of the calcarine sulcus we recognized in the last lecture. Calcarine sulcus floor is the calcar avus. Inferior horn in the temporal lobe is the largest of the horns and lies in the temporal lobe. This is the anterior horn, this is the atrium, this is the inferior horn. See, it's all in the temporal lobe. Of course, they vary in size. The roof is formed by the tapetum of the corpus callosum, tail of caudate nucleus, and stria terminalis. The floor is formed by the collateral eminence, which overlies the collateral sulcus. Remember the parahippocampal gyrus. The sulcus next to the parahippocampal gyrus at the inferior surface is called the collateral sulcus. Its floor forms or pushes the collateral eminence in the floor of the inferior horn of the lateral ventricle. And hippocampus medially covered by the alveus. We will take the hippocampus, we will study the hippocampus and its formatio hippocampi in the limbic system. Okay. The third ventricle is the space between the two thalami. Cavity, it's the cavity of the diencephalon, I mean. The roof is formed by ependema and tilla choroidi. The floor by the optic chiasma. This is the optic chiasma here. The infundibulum. The tuber cinereum, which is the top of the infundibulum, and the mammillary bodies. This is a mammillary body. It's part of the hypothalamus and posterior perforated substance. So again, the optic chiasma, the infundibulum, the tuber cinereum, the mammillary bodies, and the posterior perforated substance here. This is the floor of the third ventricle. Anteriorly, it's bound by the lamina terminalis. This is the lamina terminalis. And the fornix, which underneath you will find the interventricular foramen of Monro, and anterior commissure as well. So the lamina terminalis, the fornix, and anterior commissure. Posteriorly, there is the pineal gland here, and posterior commissure, as you can see here, and the cerebral aqueduct of Sylvius. See, this is the aqueduct of Sylvius running in the midbrain, and the habenular commissure between the two habenular bodies or nuclei, and we will study this in the limbic system as well. Laterally, upper tooth laterally means the walls, upper 2/3 by the thalamus, as you can see here, and lower part by the hypothalamus, because this is the hypothalamus, this is the thalamus, this is the hypothalamic sulcus that separate both thalamus and the hypothalamus, in addition to the subthalamus, which is the part of the diencephalon right above the midbrain. This is the subthalamus. There are interthalamic adhesions between the two thalami. By the way, sometimes it's not present, and communicates to the fourth ventricle. This is the fourth ventricle through the cerebral aqueduct of Sylvius. It has minute recesses like the infundibular recess. This is a recess. This is considered a recess. This is optic recess, and pineal recess, and suprapineal recesses. So this is the third ventricle. Remember, it's the space between the two thalami. The fourth ventricle, this is the fourth ventricle, actually the floor of the fourth ventricle. Posterior view, this is posterior view of the brainstem. This is midbrain, this is pons, and this is medulla oblongata. And remove the cerebellum so as to reveal the floor of the fourth ventricle. It's the cavity of the rhombencephalon, And lateral boundaries, you can say from above downwards, the superior cerebellar peduncle, then inferior cerebellar peduncle. The middle cerebellar peduncle, by the way, it's not a boundary. Superior cerebellar peduncle, inferior cerebellar peduncle, gracile and cuneate tubercles raised by the gracile and cuneate nuclei. The roof, it's removed here because it's the superior medullary velum of the cerebellum. The floor is what you see here. You can recognize the median sulcus and another sulcus. It's called the sulcus limitans. The sulcus limitans, by the way, lies over a nucleus called the locus ceruleus or nucleus ceruleus in the pons of the brainstem. It's part of the reticular activating system. There's a medial eminence. This eminence is the medial eminence. It's raised by the medial longitudinal fasciculus. We will study this in the structure in the brainstem. And a facial colliculus. See, this is the facial colliculus. It's produced by or raised by the facial nerve curving around the abducens nucleus. Vestibular area, stria medullaris or medullary stria. They are cerebro-pontocerebellar fibers. And the hypoglossal triangle is the triangle most medial here that you can see here, raised by the motor nucleus of the hypoglossal nerve. And a vagal triangle overlies the dorsal motor nucleus of the vagus nerve. This region is called the obex, which is the opening of the medulla. And gracile and cuneate tubercles. This is gracile. These are gracile tubercles and then cuneate tubercles. It communicates through foramina of Magendie and Luschka to the spinal cord. This is foramina of Magendie here, and at the sides to the outside of this spinal cord. So from here to the inside of the spinal cord, foramina of Magendie, and through foramina of Luschka at the sides to the surrounding of the spinal cord. That was a description of the floor of the fourth ventricle. So remember that the middle cerebellar peduncle does not share in the boundaries of the fourth ventricle. Of course, the fourth ventricle, as you know, communicates by the cerebral aqueduct of Sylvius to the third ventricle and by foramina of Magendie and Luschka to the spinal cord. Now, a hint about the CSF, cerebro-spinal fluid. It's formed by the choroid plexus in lateral ventricles, in the ventricles in general, and in the third and fourth, and lateral. Also, small amounts formed by the ependymal lining and the arachnoid matter and the brain itself. It's formed in the perivascular space, as we will see later. Mechanism of formation, it's by sodium active transport pulling chloride with it. This increases the osmotic pressure, so withdraws water with it. And some glucose goes into the fluid, and potassium and bicarb goes out of the fluid. So in composition, you'll expect that the chloride is more than that of plasma. Potassium is less than the plasma. It should be free of cells, free of blood. If you see any cells or any blood, this suspects infection or hemorrhage. Now, if you withdraw some CSF sample from the lumbar cistern, we studied in anatomy at the lower end of the spinal cord. It's called the lumbar puncture. The pressure is less than 200 millimeter of water, and the pressure increases in tumors and intracranial hemorrhage and hydrocephalus. The color should be clear and colorless. It's like water. If you see it, if you see a sample, you can't distinguish it from water. It's cloudy in bacterial infections or red tinged in hemorrhage. Cells, there should be no RBCs and less than 5 lymphocytes in field, microscopic field. You will see increased numbers in hemorrhage, increase white blood cell count in bacterial and viral infections. Glucose decreases in infections, in bacterial and fungal infections, because it's consumed by the polymorph nucleoleucocytes attracted to the site of infection. Lactic acid increases in bacterial or fungal meningitis, and glutamine increases in hepatic encephalopathy. Okay, that was a hint about the structure of the cerebro-spinal fluid. Now the cycle. Now the thylakoid in the ventricles form the CSF. It fills the lateral ventricles. See that? And then through the interventricular foramen of Monro to the third ventricle, and through the third ventricle through the aqueduct of Sylvius to the fourth ventricle, and here through foramina of Magendie to the central canal of the spinal cord, and Luschka to the outside of the spinal cord. See that? And then to the outside of the brain, where it's drained by the arachnoid granulations. Okay, subarachnoid hemorrhage may cause hydrocephalus in adults because it interferes with CSF absorption in newlyborns. It's due to obstruction of CSF path. Meningitis occurs in the leptomeninges, in the arachnoid and pia mater. Okay, so this is the circulation of the CSF again. It fills the ventricles, lateral ventricle, ventricular foramen of Monro to the third ventricle, aqueduct of Sylvius to the fourth ventricle, foramina of Magendie to the central canal, and Luschka to the outside of the spinal cord. Now it continues up surrounding the brain to be drained in the arachnoid granulations into the superior sagittal sinus. Drainage by arachnoid villi, which are projections of the, as you can see here, arachnoid membrane, forming arachnoid, what's so-called arachnoid granulations. These granulations, by the way, leave an impression on the inside of the skull. The endothelium of which has holes for passing of CSF, and it drains it into the nearby durovenous sinuses. Major drainage, of course, in the superior sagittal sinus. And the arachnoid villi have valve-like action, means blood passes in one direction from, the CSF passes in one direction from the subarachnoid space to the blood, drainage occurs if the CSF pressure is about 1.5 millimeter mercury more than the venous blood in the sinus. Okay, impaired drainage due to blockage by RBCs in hemorrhage, for example, white BCs and proteins in infections, fibrosis post-meningitis. That's why meningitis, the complications of meningitis involves hydrocephalus if obstruction occurred at the drainage site. And if they are few in number, like in newlyborns, for example, or in case of tumors, especially above the tentorium cerebelli, that prevents upward flow of CSF through the tentorial notch, leading to increase in pressure below the tentorium cerebelli. Okay? Hydrocephalus, pardon me. Hydrocephalus means excess water in the cranial cavity. It's two types: communicating type, blockage at arachnoid villi, usually in basal areas, fluid increase inside and outside because it's at the level of arachnoid granulation, so the whole circulation is affected. And tremendous increase in size that will give rise to certain signs such as sunset sign, as you can see here, sunset sign, failure of closure of fontanelles, and of course enlargement of the skull. The non-communicating type means there's a blockage of somewhere in the CSF path, especially in the aqueduct of Sylvius, by congenital deformities or tumors. Pressure increases in lateral and third ventricles, and treatment is surgical by silicone rubber tube connecting the lateral ventricle and peritoneal cavity, and of course it has to be changed with age. Now there's a space called the perivascular space, formed by the pia mater because it's loosely adherent to the vessels. This is the perivascular space, as you can see here, leaving a space that follows the arteries and veins, and small amount of protein leak through the vessels in the perivascular space, and this is considered as the lymph drainage of the brain. Now, a blood CSF barrier exists. Don't confuse it with the blood-brain barrier. There is between blood and CSF. It's present at the choroid plexus. It's logic. Tight junctions between the choroid epithelial cells and not the capillary endothelial cells. It's between the choroid epithelial cells. Blood-brain barrier is formed by the astrocytes. We studied by the podocytes of astrocytes, as you can see here. This is the blood-brain barrier. It's formed by the endothelium, lamina of the blood vessel, and the podocytes of the astrocytes converging on the blood vessel, except in certain places like the choroid plexus, hypothalamus, pineal gland, and area postrema and the medulla. If you think about it, this is because these areas detect osmolarity and glucose levels in blood, so they have to be exposed. They have to be exposed to blood. Structures passing are lipid soluble, like alcohol and anesthetics, carbon dioxide, O2 and H2O. Slightly permeable to sodium, chloride, and potassium, and impermeable to plasma proteins, non-lipid soluble large molecules. This is the blood-brain barrier. So if you prescribe a drug that's central acting, means it acts on a brain, it has to pass the blood-brain barrier to exert its effect. Functions of the CSF, because it's a fluid that surrounds and fills the brain, means from the inside and outside it acts like a cushion. Now, because of same specific gravity of plasma, the brain is floating. Now, if you measure the weight of the brain, its averages between 1.5 kilos and 2.5 kilos. That differs between males and females. But if you put an electrode or probe below the brain in situ, inside the skull, it will weigh around 200 grams only, because the brain is floating. If you take out the brain and put it on a table, it will collapse. Why doesn't it collapse on the base of the skull? Because it's floating. The same principle as what they call the suicide of whales. The whales they do not commit suicide just with the low tide, because they are mammals. They have lungs, they have thoracic cage, they touch the ground, so their body weight exerts its effect on the thoracic cavity, they cannot breathe. That's why they die. The same principle with the brain. The brain maintains its shape inside the skull because it's floating. It's a crucial action. That's why you give when you perform an lumbar puncture and you withdraw sample of CSF from a patient, you give him a juice right after the procedure, because he starts to feel some headache. This is a normal sign after the lumbar puncture. Okay, in trauma, a type of injury called the counter coup, especially in boxers, they take a hit from front, but the injury occurs at the back because of the inertia of the brain. It has some nutritive function to the brain, and it acts like a sink, washes unwanted materials, and it helps in movement of substances from the brain to the blood. These are the functions of the CSF. I hope you got the maximum benefit from this lecture, and thank you very much for watching.